Hi, I'm Park Ji-hoon, working in Seoul National University Bundang Hospital. Uh, it's my honor to be here to present my recent research about the diagnostic accuracy of CT for evaluating circumferential resection margin status in resectable or borderline resectable pancreatic head cancer. Many guidelines on pancreatic cancer management now recommend neoadjuvant therapy over upfront surgery for patients with borderline resectable cancer. See, in this treatment strategy, CT plays a central role in determining the resectability of pancreatic cancer, which directs the use of neoadjuvant therapy. However, there's materials regarding the diagnostic accuracy of CT in determining circumferential margin status at which most positive resection occurs. So the purpose of this study was to measure the diagnostic accuracy of CT in predicting the circumferential resection margin (CRM) status in patients with resectable or borderline resectable pancreatic head cancer. This was a prospective observational study conducted in 2014 to 2018, and we obtained IRB approval, and informed consent was also obtained from each patient. Eligible patients were over 18 years old of age and having resectable or borderline resectable pancreatic head cancer, and who underwent upfront surgery without neoadjuvant therapy. We obtained dynamic contrast enhancement CT, including pre-pancreatic parenchymal and portal venous phases. We invited 3 abdominal radiologists, and they rated the CT resection margin status on a 3-point scale, wherewith the score 2 indicated involved resection margin status, and score 1 indicated very close. That is the distance from tumor to presumptive resection margin lie between 0 to 1 millimeter. And score 0 indicated no involvement at the CT resection margin, which means that the tumor to presumptive resection margin distance was larger than 1 millimeter. We instructed the readers to presume that the outermost surface of SMA margin should be the SMA resection margin. Likewise, the outermost surface of the IVC or SMVPV should be regarded as the posterior and SMV portal vein resection margin. As a reference standard procedure, we used the axial slicing method proposed by the Royal College of Pathologists. Using this method, we slice the specimen in 3 to 5 millimeter thick slices following an axial plane perpendicular to the duodenal axis, which is very similar to the plane axial CT plane, so we can robustly compare the distance between the tumor to resection margins. This is the microscopic pathologic slide images. The circumferential resection margin status was evaluated microscopically, and a positive resection margin was defined as the presence of tumor cells within 1 millimeter of the resection margins. We pulled the sensitivity and specificity of the three readers using a crossed random effect model, and we measured the diagnostic performance for overall CRM status and for each SMA posterior and SMV portal vein resection margin. And the CT resection margin score equal to was considered as positive. This is a patient flow diagram. Initially, there were 285 patients with pancreatic cancer during the study period, but finally 75 patients were included for this study. This is the baseline patient characteristics. 51 patients had resectable cancer and 24 patients had borderline resectable pancreatic cancer. After surgery, 40 patients turned out to have positive overall CRM. Here's the result. We observed the low sensitivity and high specificity for both for the overall and each of resection margin status. The pooled sensitivity and specificity for overall CRM involvement was 15% and 99% respectively, and the tendency of low sensitivity and high specificity was observed for each of resection margin as well. This is a case of false negative. On CT, the normal pancreatic parenchyma was noted between the cancer and the SMA. On pathologic examination, most tumor glands were accompanied by the diffuse fibrosis in the red dotted line, while some tumor cells were noted in the relatively preserved pancreatic parenchyma. All three readers predicted the SMA resection margin to be negative, while it was positive on pathologic examination. This is another case of false negative. On CT, only subtle fatty infiltration is noted near the SMA. However, on pathologic specimen, cancer glands were seen within the adipose tissue apart from the main cancer mass. Our three readers also predicted the SMA margin to be negative, while it was positive on pathologic examination. We performed several sensitivity analyses varying CT resection margin score threshold and reference standard positivity threshold between 0 to 1 millimeter. However, the tendency of low sensitivity and high specificity was consistently observed across the sensitivity analysis. In conclusion, CT showed very high specificity but low sensitivity in predicting pathologic CRM involvement in patients with resectable or borderline resectable pancreatic cancer. The limited sensitivity of CT should be considered when establishing the future guidelines as well as in designing clinical trials for patients with pancreatic cancer. This research was supported by Seoul National University Bundang Hospital Research Fund. And thank you for your attention.